My name is Haley Bush. I'm a clinical pharmacist specialist dedicated to opioid stewardship for the Kentucky market of CHI St. Joseph Health. And today I'll be discussing how to treat a concomitant acute pain and opioid use disorder in the hospital setting. Before we get started, I just wanted to note that I don't have any conflicts of interest to disclose. And our objectives before we move forward, the first to review the pharmacology of medications for opioid use disorder in comparison to the traditional full agonists that we utilize for pain management. Next, discuss the strategies for maintaining patients on opioid use disorder treatment and also treating acute pain, and then understanding how to treat acute pain in patients that have diagnosed opioid use disorder but are not currently on medications for management of that disease. These are some abbreviations that I'll be referencing throughout the presentation. And before we move into the pharmacology, I wanted to first discuss the background of the opioid crisis, attempt to quantify it and understand how we got to where we are today. So for the past several decades, we know that we have lost nearly 500,000 people from an opioid-related overdose death, which comes out to about 110 people per day. And this includes death from both prescription opioids and illicitly manufactured opioids. The number of opioid-related overdose deaths actually increased from 2019 to 2020. We saw a dip in 2018 for the first time, and we're very hopeful that some of our harm reduction strategies with respect to managing opioid use disorder and our stewardship practices in our healthcare systems were starting to take hold, and that we, would see some change in terms of the statistics. But unfortunately, we have seen a rise again from 2019 to 2020, and it's looking like that increase is going to continue and be a pattern moving forward, unfortunately. We know that stigmatization of opioid use disorder treatment has certainly played a role into how we got to where we are today. We also know that in the past, we've emphasized pain control and promoted pain as the fifth vital sign amongst our regulatory bodies for healthcare systems, which has certainly increased prescribing habits with respect to opioids. And we also have all heard about Purdue Pharma, of course, and some of the misleading claims that have come from the pharmaceutical industry over the last several years. And all of this together has contributed to the current evolution of the opioid crisis. And we know that us as a healthcare system has to start playing a role, and we are playing a role in trying to, alleviate the burden that the opioid crisis has on our patient population and in our own community. I'm going to take some time to discuss the pharmacology behind medications approved by the FDA for the management of opioid use disorder. First, we'll talk about methadone. We know that methadone is a full mu opioid receptor agonist. And the current FDA-approved formulations that we have on the market are the oral solution as well as the dissolvable tablet. Typical dosing for methadone. So for this drug, I typically like to tell patients and clinicians that we like to start low and go slow. Methadone does have nonlinear pharmacokinetics. It also has some interesting pharmacodynamic properties as well, which make it difficult to really see the full effects of methadone within the first several days of treatment. So there are certainly several isolated case reports of patients that are very tolerant on opioids, having overdose events on methadone at very low doses unexpectedly. So we likely see some less cross sensitivity with methadone in comparison to other full mu agonists across the board. And this also means that our MME or morphine milligram equivalent conversion factors for methadone are just educated guesses. So it makes it difficult to convert from other full agonists to methadone and vice versa and have an accurate understanding for how the patient will respond to the methadone dose that we give. Thus, we start low and go slow. We also know that methadone has an extremely long half-life, up to 120 hours in some patients. So again, you're not going to see the effects of your initial dose or a dose increase from 3 to 7 days after you give that dose. So we typically start off with 20 to 30 milligrams once daily on the first day, continue that for at least 3 days inpatient before you consider a dose increase. and increase by no more than 5 to 10 milligrams per day. So we don't increase any faster than 3 to 5 days in the hospital. Outpatient, the typical titration schedule would be no more than every 5 to 7 days. And the goal maintenance dose for most patients is at least 60 milligrams a day. And this is typically once daily dosing. But we know that the very best retention rates support doses of 90 to up to 120 milligrams a day. With methadone, we know with higher doses, we do occupy more mu-opioid receptors. So if a patient were to utilize, unfortunately, other illicit substances that agonize the mu-opioid receptor, there would be less receptors available on higher methadone doses for the illicit drugs to agonize, if that makes sense. So there's a lower risk of respiratory depression with methadone in comparison to like oxycodone or hydrocodone, for example. And that's one reason that we studied methadone for the treatment of opioid use disorder. We also know that over time, once the patient is maintained on methadone, you can have mu-opioid receptor internalization, which is also very helpful for not having increased physiologic dependence and tolerance. Now, you certainly will have physiologic dependence and tolerance in patients on methadone in comparison to patients that don't receive opioids, but perhaps less so than with other full mu-opioid receptor agonists, which again makes it attractive for patients with chronic opioid use disorder. So the setting and the legal concerns with methadone. In the inpatient space, and I'll go ahead and preface it with that, since most of our providers listening to this are in the inpatient realm. The DEA has said that we can treat patients that come in with opioid use disorder without limitations or restrictions in the hospital, as long as they are admitted for a medical or surgical complaint that is not opioid use disorder or opioid withdrawal, that is their primary reason for being there. So an example would be a patient who came in through the ER with cellulitis to be evaluated, for example, and then they happen to have opioid use disorder. So their primary medical diagnosis is the cellulitis, but they happen to have OUD. So we can treat opioid use disorder with any of the medications you see on the screen, as long as it's clinically indicated for that individual patient, again, without restrictions or limitations. The problem lies in transitions of care. So what do? We want these medications to typically be chronic medications for these patients. The American Society of Addiction Medicine 2020 guidelines do recommend medications for opioid use disorder to be lifelong treatment if that's what's most appropriate for the patient. But of course, that's an individual decision between the patient and the provider. So really seeing MOUD as a chronic maintenance med, the same as we would antihypertensives or anti-diabetic medications, is a big shift in the guidelines, and something that I like to mention. So with that in mind, we have to make sure that we have a good plan to transition these patients from the hospital to the outpatient space with a good plan for continuing these maintenance medications, especially if there are limitations and restrictions for giving a script on discharge, which there are for both methadone and buprenorphine. So with methadone, we actually can't write any scripts to be filled at a retail pharmacy as inpatient providers for patients that have opioid use disorder. You could only write methadone scripts to be filled at a pharmacy to treat pain, and typically chronic pain is what we think of with methadone. So these patients have to go to licensed outpatient treatment programs to get observed daily dosing of methadone. And then again, we have those exceptions for the inpatient space, but outpatient, that's essentially the only way it works. And I like to make sure that if we're starting methadone for the first time in an inpatient, that I explain, that it's certainly a big commitment to start it, because in order to continue it in the outpatient space, they're going to have to agree to go to a methadone clinic every single day for daily observed dosing. And that can change once they're in the treatment program for at least a year. But a year of dedicated commitment to going to that clinic every day can be difficult for some people. I know it would be difficult for myself. So I like to preface that up front. I also like to say that there are not a lot of methadone clinics, geographically speaking, in comparison to buprenorphine clinics. So I always do a check to see where the patient lives, and make sure that there is a methadone clinic within a reasonable distance of their home. Because again, the expectation is that they're going to go every single day for direct observed dosing. So working with case management early on with these patients to make sure that we are in communication with their methadone clinic if they're already established in terms of their care at a clinic, so that they know that patients in the hospital, they're not just missing appointments, and that we have a smooth transition back to that clinic after they leave the hospital with an appointment either same day or day after discharge. If we need a new program, we have to make sure that program, again, will be able to see that patient day of or day after discharge. So that can make things really difficult. So it's important to work with case management on your methadone patients. Additional benefits of methadone. Of course, we have utility in comorbid pain because methadone is a very potent full mu agonist. It has a high potency, which we've talked about already. And then there is that rigid structure for the outpatient setting, which can either be a benefit or a drawback, depending on how you look at it. The next drug I want to discuss is different from methadone because it is a partial mu agonist. So it's going to partially agonize the mu opioid receptors. It, however, has a very high affinity for the opioid receptors. So it's going to find more opioid receptors throughout the central nervous system than methadone would, for example, but it's only going to partially agonize those. But the combination of being a very effective locator, if you will, of the mu opioid receptors and being a partial agonist does still lead to high potency in terms of its effects, but typically leads to less physiologic dependence and tolerance. So that's sort of how that is different from other medications pharmacologically. So FDA-approved formulations for opioid use disorder. We know that we have transmucosal buprenorphine products that are co-formulated with naloxone. I also, when I go through this, like to mention that the naloxone, as long as it's taken transmucosally, will have essentially no effect for most patients as long as they have good liver function. It's not there to have efficacy if it's taken appropriately. The idea behind co-formulating buprenorphine with naloxone is if a patient were to self-administer it via injection or inhalation, that they would not be able to essentially have the high and euphoria that we associate with buprenorphine and then other illicit mu opioid agonists that they may take in combination with Suboxone if they were to misuse it. So it's essentially a deterrent from self-administering because we would block all the mu opioid receptors. But in a healthy individual with good renal function, you should not see any effect from transmucosal naloxone. So I think that's a common misconception amongst some people, even in the medical community. We also have transmucosal buprenorphine that is formulated by itself. So it's a monoproduct entity that does not have the naloxone component. So somebody that would benefit from buprenorphine by itself potentially could be somebody with end-stage or fulminant liver disease, because where they don't have a very high ability to metabolize drugs at the level of the liver, you may actually see some absorption and clinical effects from the naloxone component if you were to take it. So that's an example of a patient that would benefit from the monoproduct transmucosal buprenorphine. Another patient population potentially is pregnancy. So we have studied traditionally just transmucosal bute by itself in pregnant patients. So that's what was recommended for a really long time. Now the ACOG guidelines actually say that either transmucosal buprenorphine, naloxone, or buprenorphine by itself can be appropriate. And then there is some rare instances where patients have a hypersensitivity to the naloxone product, and therefore they would need bute by itself. Also like to note that from a legal standpoint, we can do buprenorphine monotherapy or monoproduct in the hospital without any restrictions. But in the outpatient space, the patient would need to have documented hypersensitivity or be pregnant in order to take it. We also have a subcutaneous implant of buprenorphine. This isn't used very often. It lasts about 6 months for most patients. The reason it's not used is one, cost is very prohibitive for that particular formulation. But also if the patient needs more than 8 milligrams of transmucosal buprenorphine to maintain their opioid use disorder, then this formulation won't be effective. It just won't be potent enough. It doesn't release enough drug. And then the last formulation is an extended release subcutaneous injection that lasts about a month in patients. And this can be utilized in patients that have previously tolerated transmucosal products at whatever dose is most appropriate for them. You usually start off at 300 milligrams of Sublocade, which is the ER subcutaneous injection. And then you can go down to 100 milligrams per month if the patient tolerates it. The only issue with that is, of course, cost. Typical dosing, since usually what we see for patients is the transmucosal formulations, and that's what's typically studied as well for opioid use disorder, at least. I like to list that there. So anywhere from 8 to 24 milligrams a day has been shown to be effective to maintain patients with OUD. If you look at the package insert for Suboxone or Subutex, it will tell you that you can go up to 32 milligrams for daily dosing. But in Kentucky, we do cap that dose at 24 milligrams legally. Clinically, however, just understanding that you could go up to 32 milligrams. In terms of legality and which settings we can give bup in, I already talked about how we can do it inpatient as long as we have a patient who's admitted with a medical or surgical complaint that's not OUD. And we think that opioid withdrawal would complicate the medical stay, which when would it not? However, the issue lies in transitions of care. So we have to have an ex-DEA waivered provider to give a prescription for Suboxone to be filled at a retail pharmacy. Or what we do more commonly is make sure that we connect the patient with a Suboxone clinic immediately at discharge, so that they, don't have so that we close the loop essentially in terms of transitions of care. Some other benefits for buprenorphine. So all I've talked about so far are FDA-approved products, bup products for OUD. We know that there are other bup products that are FDA-approved for pain. We also know, although I didn't mention it previously, that methadone is FDA-approved for chronic pain. So there are a couple of bup formulations that have been approved for chronic pain and then one for acute pain. So that tells you that we have good efficacy of bup with pain management. So we have Butrans or transdermal buprenorphine, which is FDA approved for chronic pain. And then we have Belbuca, which is a buccal formulation of buprenorphine that is FDA approved for chronic pain as well. And then we also have Buprenex, although we typically don't keep it at our hospitals in the health system, which is FDA approved for acute pain. It's an injectable IV buprenorphine product. We also know that because we have partial agonism at the mu receptor, we typically have what's referred to as a ceiling effect for respiratory depression with buprenorphine. So it makes it a little bit safer, if you will, in comparison to other full agonist therapies. Naltrexone is the last one. I won't spend too much time on this because it's just not utilized and promoted as first-line treatment by guidelines as much as our agonist therapies, which would encompass both methadone or buprenorphine, which we've talked about at length at this point. So naltrexone is a full antagonist at the mu opioid receptor. It has lower retention rates in comparison to our agonist therapies, which makes sense. Patients would typically do better in terms of craving and withdrawal symptoms with an agonist versus a full antagonist. With naltrexone, the patient has to be opioid free for about a week and have a negative urine drug screen. We give a oral test dose of naltrexone to make sure the patient handles it okay and doesn't have withdrawal symptoms. And then for most patients, what's most appropriate is the extended release intramuscular injection. It's 380 milligrams of naltrexone that lasts about 28 days for most patients. The oral tablets are just typically not utilized anymore because of really, really low retention rates, which can potentially, have less of a mortality benefit for patients, as well as morbidity benefit. This can be given in any medical setting because there are no agonist properties. There's no physical dependence and less stigma associated with it, not only in the healthcare setting, but in the addiction medicine community as well, and rehab facilities. It's more, it's just seen as less of a crutch, I guess, than agonist therapy. But again, retention rates, mortality rates, really show best benefit with agonist therapy. And guidelines recommend agonist therapy as first line unless the patient does not want it or is not appropriate to receive it. Okay, let's move on. So why do the ASAM or the American Society of Addiction Medicine 2020 guidelines promote agonist therapy? We know that methadone is currently the most used and most studied medication for OUD globally. That's just because it's been around longer than buprenorphine. We know that methadone and buprenorphine reduce overdose-related deaths. They reduce the risk of HIV and hepatitis C infection, reduce criminal behavior, and reduces illicit opioid use more effectively than placebo or detox without medication management. So pulling together all of the statistics that I just showed you, and this comes from several systematic reviews, which stem from several randomized controlled trials, specifically looking at patient behavior mortality rates and morbidity rates in patients that have OUD that get agonist therapy treatment in comparison to those that don't. So this particular cohort study wanted to retrospectively look at a specific national cohort of insured individuals by CMS between 2015 and 2017, and basically see, are those benefits seen in real life in the American population? And also compare different treatment pathways in terms of efficacy for the management of OUD. Their primary outcome for this retrospective cohort study was looking at rates of overdose or serious opioid-related acute care use, so needing to go to the hospital to get treatment for something related to OUD. So they had several different treatment groups. They had an MOUD treatment group with agonist therapy, so either buprenorphine or methadone, and they lumped that group together. The second group was opioid antagonist therapy. So this would be something like naltrexone, inpatient treatment, which is typically rehab without MOUD, intensive outpatient behavioral interventions without MOUD, and the only treatment course that showed a significant decrease in overdose or serious opioid-related acute care use was the agonist group. So we saw a 76% reduction in overdose at 3 months with either bup or methadone on board, and a 59% decrease in overdose at 12 months, again with either bup or methadone maintenance therapy for those patients with OUD. So these numbers, to me at least, are staggering and really show the benefits in terms of mortality, because we know overdose is often a fatal event for these patients with the initiation and or continuation of bup and methadone. So it just shows you how important these medications can be in terms of changing outcomes for these patients with opioid use disorder. And this is why those 2020 guidelines recommend agonist therapy over detox programs for patients that are willing to initiate agonist therapy, because we really can change their lifespan. So now moving into how to control acute pain in patients that are on these medications. So here are some 4 common misconceptions. And again, I'll spend the most time on our agonist regimens, but we'll certainly talk about naltrexone as well, because that has come up clinically, within the last several years. So the first misconception is that MOUD maintenance provides adequate analgesia in and of itself. That is not accurate for patients. That would be like a patient that has a cancer diagnosis that's maintained on a certain fentanyl patch dose, let's say 50 mics per hour, coming into the hospital for surgery, and the only thing we give them is their baseline fentanyl patch. We know that they're going to have acute on chronic pain in that situation, and that we're going to need to give short-acting full agonist opioids on top of reestablishing their baseline opioid medication by restarting the fentanyl to really get that acute pain under control. The same principle applies to patients that have opioid use disorder. So when they come in, we have to reestablish baseline by giving them, their standard medication to treat opioid use disorder. And then we have to use short-acting opioids to treat any acute breakthrough pain on top of that. Otherwise, you're not going to have good pain control. Use of additional opioids may result in opioid use disorder relapse, as long as we are judicious, which we should be with all patients, right? So using the lowest dose for the shortest duration, and making sure that we continue OUD treatment and not have a lapse in therapy is the two most important things in terms of managing relapse. The next is that opioids and MOUD will cause respiratory and CNS depression. Again, these patients have a high level of physiologic tolerance and dependence, sometimes less than chronic pain patients that are maintained on full agonists like fentanyl patches or MS-Contin or Oxycontin, but they still have a high level of physiologic tolerance and dependence. So adding short-acting full agonist opioids at moderate to high doses is just going to get the pain under control. It's typically not going to increase rates of respiratory or CNS depression. Pain complaint may be a manipulation. That's just rooted in stigma, and is something that we have to work through as healthcare providers if that's a thought in the back of your mind while taking care of these patients. Analgesic properties of bup and methadone. I want to remind you that these are potent analgesics in and of themselves. However, the way that we typically dose them for opioid use disorder is not typically conducive for pain management as well. The duration of action for analgesia for both bup and methadone is only about 4 to 8 hours. So it has a short duration of action in terms of pain control, but to suppress opioid withdrawal, it lasts much longer. So suppression of withdrawal and cravings can last 1 to 2 to maybe even 3 days with methadone. But for both of these, the duration of action for pain control is only 4 to 8 hours. So keep that in the back of your mind as we talk about strategies for managing acute pain and also continuing MOUD in these patients. Methadone. So we know this is a Schedule II synthetic opioid agonist. It has some other properties as well. It's going to inhibit reuptake of serotonin. It is going to also have some NMDA antagonism, which can be very helpful for patients that have neuropathic pain conditions. We've already talked about how there's wide variability in pharmacokinetics. There's some inter-individual variability as well. So how one person reacts to methadone may be entirely different than how someone else does. We know there's a risk for QTC prolongation with methadone, so always establishing a baseline for these patients and rechecking a QTC before you increase a dose is really important, or if you add a concomitant medication in the hospital that can prolong the QT interval. And then we've talked about how the elimination half-life is very long as well, but there is, again, that interpatient variability. So somewhere between 5 to, some studies say 120, others say even as high as 130 hours. So it does take a very long time, sometimes 4 to 10 days, to really achieve steady state pharmacokinetically in patients that are starting methadone for the first time, or if we're increasing the dose. General approach for managing acute pain in patients that are concomitantly maintained on methadone. There's no really guidelines or consensus statements that really show you how to do this. So this comes from expert opinion. It comes from retrospective case reports, and I'll show you some of that data moving forward. But the general idea here is we want to reestablish baseline. We want to continue to treat opioid use disorder as a chronic disease course, and we want to continue methadone treatment. We also know that if we try to make up for the patient's opioid deficit when we stop methadone by giving other medications, it's hard to do dose finding because the MME conversion factors for methadone are notoriously inaccurate because they have to take into account interpatient variability, these erratic pharmacokinetic profiles as well of methadone. So it makes it very difficult to be accurate in terms of dose conversions. We also know that we want to maximize multimodal non-opioid analgesic strategies. We could give a whole presentation on what that means. So just take that at face value, understanding that typically means Tylenol if appropriate, NSAIDs if appropriate, regional anesthesia techniques, topical management if it's appropriate for a patient. Sometimes it means ketamine, which is a potent NMDA antagonist that at subanesthetic doses can be useful for pain management. Again, there's a wide variety of what this can mean, but we know that if we can avoid the opioid receptor, not only in these patients, but in most patient populations, we typically can see similar pain control, but better outcomes long-term. Supplement with incremental additional short-acting opioids if necessary during a period of acute pain, tapering them off as quickly as possible, and individualizing the plan, also staying flexible, understanding these patients will usually need higher starting doses than your opioid naive patients. And then we've already talked about this a little bit, but coordinating with other care providers, especially the patient's methadone clinic, so that they know what's going on, they know why the patient is missing appointments, and they plan to see the patient imminently upon discharge. This is a study just showing the benefits of multimodal pain management in patients that are maintained on methadone. It's the only randomized controlled trial that I could find just to show the ability of a non-opioid analgesic to help with opioid-induced hyperalgesia or with pain control in patients. So the purpose of this 2010 randomized controlled trial, which was really small, only had 26 patients in it, was to assess the ability of gabapentin to decrease opioid-induced hyperalgesia in methadone-maintained patients. So they wanted to take methadone-maintained patients, give them gabapentin, and they up-titrated this to 2,400 milligrams a day in short increments over a week span. And they wanted to look at their change in pain scores before and after starting the gabapentin treatment. So they looked at the change in pain threshold and tolerance from baseline to week 5 by looking at a cold pressor test. So they basically put the patient's hand into a cold water bath, their non-dominant hand, and then with their dominant hand, they would press a button when they first felt pain for the first time, and then when they, the pain got so difficult that they had to remove their hand. So those were surrogates for pain threshold and pain tolerance. And again, looking from baseline to week 5. They also did these tests at both peak and trough methadone levels, and they separated the peak and trough by about 72 hours to basically see if that influenced pain threshold or tolerance at all in terms of where we were in methadone dosing. And patients had to be maintained on methadone for at least 6 months to be included in the trial. So the results showed that the gabapentin group demonstrated a statistically significant improvement in both pain threshold and tolerance. And you can see that here on the screen with the graph compared to the control group. So again, showing that the addition of gabapentin was helpful in terms of managing that acute pain when it came on in these patients that were maintained on methadone long-term. These different cohort studies or case control studies are here to show you methadone's effect on cross tolerance. So really to prove the point that patients that are on maintenance methadone may need novel treatment strategies for acute pain management and typically need higher opioid doses in terms of their breakthrough medications, their short-acting breakthrough medications, than patients that are not on any opioids at baseline. But that should not be very surprising to you, considering we've certainly seen other patients with physiologic tolerance and dependence need higher doses acutely for short-acting opioids as well. However, although it hasn't necessarily been proven in these studies, I would imagine based on what we know pharmacologically that patients maintained on methadone have less physiologic tolerance and dependence than like a chronic pain patient maintained on a fentanyl patch or Oxycontin or MS Cotton, for example, but that's just speculation and expert opinion. So this first case control study over here on the left is a relatively small study with 36 patients in it from 2017. This was looking at unilateral total knee arthroplasty patients that were on chronic methadone compared to a matched control group for age, sex, and BMI. And the matched control group were not on any opioids. So these were opioid naive patients at baseline. And they wanted to specifically look at and see if chronic methadone use resulted in more opioid use during the inpatient stay. And in terms of the pain management cocktail for these patients, they used the same regimen for the opioid naive patients compared to the opioid tolerant patients on methadone. So the treatment protocol or the study protocol at this facility was to utilize Toradol, Tylenol, Lyrica, and then allow oxycodone for breakthrough pain. And then if pain persisted beyond that, patients could get intermittent IV Dilaudid on post-op day 0 or post-op day 1. And if that didn't work, then they would escalate to PCA utilization with IV morphine. So there was significantly higher need for more oral morphine equivalents in the patients that were receiving methadone in comparison to the control group. So you can see almost a threefold increase in terms of the morphine equivalents required to get pain under control when pain escalated to PCA utilization in the methadone group in comparison to the control group. But again, not surprising. This next is a 2016 prospective matched cohort study with 51 patients. These were total joint patients with documented pre-op treatment with either methadone or Suboxone, so not just methadone, compared to a matched control group, again, for age, sex, and BMI, as well as the type of procedure the patient was having, since this included multiple different types of joint arthroplasties. Patients that were receiving either Suboxone or methadone did need higher opioid prescription doses at discharge in comparison to the control group. But again, these were opioid naive patients. Although the study did not report it, I would imagine that those patients required more opioids inpatient, which necessitated a higher dose for outpatient pain management as well. But again, that just lets you know that we need a different treatment plan, most likely for patients that are opioid tolerant compared to naive, whether it's tolerant with MOUD or tolerant with any other full agonist for chronic pain management. And then the last is a 2007 retrospective match cohort study with 68 patients. They looked at patients that were postpartum. They also looked at intrapartum pain scores as well as opioid burden. These patients were maintained on chronic methadone compared to a matched control group that was, again, opioid naive. Some of the patients had a cesarean section, some had a normal vaginal delivery. Patients that had a vaginal delivery had significantly higher pain scores, but did not get more opioids in the methadone group compared to the control group. Cesarean delivery patients required 70% more opioid analgesia in the postpartum period in comparison to the matched control group. And you can see that here on the screen, and that was statistically significant. They also had higher pain scores. So again, not surprising, just telling us that we need a different treatment approach in patients that have opioid tolerance at baseline, and that patients that are maintained on MOUD should have their baseline reestablished inpatient, understanding we have to be flexible and have a individualized treatment plan in mind that incorporates multimodal pain management, as well as typically higher dosed short-acting opioids to get good pain control in place for these patients. So as we talked about before, when we're adding short-acting opioids to methadone maintenance, if we're talking about a patient that has physiologic tolerance independence, we usually do some MME calculations to decide how much short-acting opioids to give. But for methadone, it's difficult to do that because those MME conversion factors are notoriously inaccurate. So you can't really utilize that as a way to give a good starting dose for short-acting opioids. So we use empirically higher doses than with opioid naive patients, and some expert opinions recommend around an oxycodone 15 milligram dose instead of 5 or 10, which we would typically use first line for opioid naive patients. And then, to stay in tune with the patient, check in with pain control pretty frequently and be able to do fast titration for those patients. Most experts do agree that giving these medications on a schedule is more beneficial for patients as well to get good pain control, especially within the first couple of days of the acutely painful event, instead of on a PRN basis. So we're kind of staying on top of the pain, if you will. IV bolus administration is, of course, indicated for rapid onset of severe pain. And then if patients continue to need those IV intermittent doses beyond the first 12 or 24 hours, considering transitioning to a PCA. And then we don't want to use mixed agonist or antagonist like Stadol or nalbuphine in patients that are maintained on methadone because we could send the patient into precipitated withdrawal. Now moving into buprenorphine. So this is a Schedule 3 opioid. It is about 30 times the potency of morphine if you look at the average of most studies. And again, that's because it has a very high affinity for the opioid receptor, even though it's a partial agonist. So that's difficult, I think, sometimes clinically and pharmacologically to wrap your mind around. It does have activity at various different opioid receptors. We know, again, it's a partial agonist at the mu receptor with very high affinity and slow dissociation. So it's going to come off the receptor very slowly in comparison to most other medications as well, which again likely contributes to its high potency. It also antagonizes the delta and kappa opioid receptors with high affinity, leading to less physiologic tolerance and dependence and less ADRs that we typically associate with opioids, including respiratory depression. We know it's a weak inhibitor of serotonin and norepinephrine reuptake. It is a sodium channel blocker as well, which is a similar mechanism to our local anesthetics, which can be helpful for pain. And we know that if we just give buprenorphine to somebody who is maintained on chronic full agonist opioids without having a proper period off of them at standard doses, that we can induce precipitated withdrawal. There's also the legal considerations to keep in mind for the outpatient dosing. So having a XDEA waiver is a requirement for patients for providers if you're going to give a discharge prescription. We talked a little bit about this already. So because buprenorphine is a partial agonist, that has a high affinity for the mu opioid receptor with the slow dissociation, we typically see less ADRs like respiratory depression and euphoria, physiologic tolerance and dependence, but we see good pain control and good ability to keep cravings under control. Opioid conversion factor for buprenorphine is notoriously inaccurate as well, just because there are unique properties for bup and methadone that are difficult to account for in a single patient with a single number across the board. However, most studies indicate, as I mentioned earlier, that 1 milligram of sublingual buprenorphine may be close to 30 milligrams of oral morphine. And animal studies suggest somewhere in the 25 to 80 milligram range. And you can see the MME conversion factor table over here on the right. General approach for managing acute pain and concomitant maintained patients on buprenorphine products. We want to continue buprenorphine, and I'm going to show you really some evidence for that in a couple of slides because that may not make a lot of sense at this point in time. We want to maximize multimodal non-opioid analgesic strategies, same as we would for methadone, same as we would for any patient. We want to try to avoid the opioid receptor if we can, because we know the ADRs associated with agonizing the mu opioid receptor, and we know the collateral damage that can result. Consider increasing the bupe dose for mild to moderate pain. So if a patient comes in with really superficial cellulitis without an abscess, for example, you may be able to increase your total daily bupe dose as long as we don't exceed 24 milligrams in Kentucky, and give it more often. You could give it up to 3 times a day potentially for patients as long as they meet the Kentucky legal criteria for split dosing. That's going to maximize that short duration of analgesic efficacy that bupe has, which is only 4 to 8 hours, and maybe sufficient enough to treat pain without adding on additional short-acting full agonist opioids. But if we have pain that is not controlled with that strategy, or if it's more in the moderate to severe pain, we know that we don't typically have a choice but to supplement with incremental additional short-acting opioids for severe or, again, that undertreated acute pain. Again, the same plan here, being flexible, being able to individualize that for the patients pretty rapidly, and then tapering it off as soon as possible. And then also coordinating, of course, with our Suboxone clinic as well, the same as we would with methadone clinic, especially if we're not able to give a discharge prescription for bupe, because we want to have a closed loop communication with our patients, especially when it comes to something as important as maintaining sobriety and having a good plan for lifelong management of OUD. So here are some misconceptions about buprenorphine that I hope to debunk. So this is the thought process that had been around for several years, and I want to paint the full picture. There are certainly some isolated case reports that dictate and show examples of patients that have not had good pain control until bupe was discontinued in favor of doing exclusively full agonist opioids. But the preponderance of most more recent observational studies, case series, as well as case reports have really shown that you can have good pain control if you continue buprenorphine, and we may actually need less short-acting full agonist opioids to manage pain in patients if we continue bupe versus stopping it. And I'm going to tell you why that is in a few slides. So in the past, we thought if a patient was maintained on buprenorphine, which has a high affinity for the mu receptor, but is only a partial agonist, and we introduce full mu opioid receptor agonists for acute pain control, there would be competition and an adequate pain control. However, again, there's a growing body of evidence demonstrating that effective analgesia can still be achieved if we continue buprenorphine during an acutely painful period, even in the perioperative phase. So here's the truth about buprenorphine and pain. If we discontinue bupe in a period of acute pain, we create an opioid deficit. Same as we would a cancer patient who comes in on a fentanyl patch. If we stop that fentanyl patch, we have to make up for it in other ways and then also get acute pain under control. So we have to replace the opioid deficit and then also get pain under control. So the patient may actually require higher doses of full agonist opioids to get pain within a reasonable range. And then we also have on top of that issue, complex transitions of care and a potential increased risk for return to illicit opioid use on discharge. Once we stop bupe, it's very difficult to get it back on, especially if we are in an acutely painful period. So when the patient leaves, if there's not a good plan to get them back on it immediately, then they are at the highest risk for relapse, overdose, and overdose-related mortality, which makes things really difficult to justify discontinuing buprenorphine if we have the ability to continue it in the hospital. So here's some supporting literature to show you that we can have good pain control with the continuation of buprenorphine, despite the fact that it is a partial agonist with slow dissociation and a high affinity for the mu receptor. So this first study over here on the left is from 2006. It's an open label study with 29 patients. These were oncologic patients admitted to an inpatient palliative unit. Their baseline pain control was transdermal buprenorphine, so a Butrans patch. And that was, again, that basal pain control. And then the intervention was if they had severe breakthrough pain, which was quantified as a 7 to 10 on the numeric rating scale, they would press their nurse button. The nurse would come in and give an IV morphine dose that was 1/5 the amount of their Butrans patch dose in terms of using MME conversion factors. They would look at their pain score before morphine administration and
May I
15
have your
minutes
attention,
after morphine
please?
administration.
Would the owner of a Chevy Silverado gray in color please move your vehicle out of the main front entrance? It's been unattended. Again, please, that is a gray Chevy Silverado in the main front entrance, unattended. Please move your vehicle. Thank you.
So they would basically see if the morphine was effective in terms of pain control. And for 93% of the breakthrough pain episodes, it was efficacious. And when, in the about 8.5% of patients that it was not efficacious, they were able to get a half dose of IV morphine, so half of their total basal pain control rate. So, and they really didn't see any ADRs in any of these patients, again, demonstrating we can have good pain control with reasonable doses of IV morphine that are individualized for that patient while continuing basal buprenorphine. This next study was an interesting one. It was actually a randomized controlled trial from 2009 with 120 patients. These were post-op patients undergoing a variety of different major abdominal surgeries. They had several different intervention groups. Essentially, they allowed either basal buprenorphine or basal morphine on top of either breakthrough buprenorphine or breakthrough morphine. And they had 4 different groups to make sure that, all the different combinations could be utilized by those patients and that we could study them. So the addition of buprenorphine to a full agonist did not inhibit analgesia provided by the morphine itself. It also did not induce any undesired sedation or respiratory depression events either. In fact, the patients that had the best pain control were the patients that received basal bup plus buprenorphine boluses. And that's likely contributed to the heavy potency of buprenorphine. This next one is a 2017 retrospective cohort study in C-section patients. And they specifically looked at postoperative pain control in patients with opioid use disorder that were maintained either on methadone or buprenorphine. So they were able to compare the 2 groups. So it was widely accepted that if a patient was maintained on methadone for OUD while they were admitted to the hospital, to restart that while they were with us, but not necessarily for buprenorphine, because it was thought to really compete with those mu opioid receptors and not allow for good pain control. So they looked at pre-op, intra-op, and post-op oral morphine equivalents, post-op complications, as well as length of stay. There were no significant difference in terms of morphine requirements in either group during any of the periods, no difference in complications, no difference in length of stay. And again, methadone's a full agonist, buprenorphine's partial agonist. So, and this shows you that there was no difference in terms of pain control, complications, or length of stay. So I think this particular study, especially considering we had 185 patients in it, 88 of which were receiving bup during the perioperative period, having similar pain control to patients that were continued on methadone, just demonstrates that perhaps that inhibition or that competition of buprenorphine is more of a preclinical issue that we have seen, and really in vivo, we see the availability of mu opioid receptors available for agonism. Over here on the left is a 2013 retrospective cohort study in post-op patients with a variety of different surgical procedures maintained on perioperative buprenorphine or methadone for opioid use disorder that were prescribed on post-op day 0 a PCA for acute pain control. In terms of their outcomes, they looked at pain relief and opioid requirements in the first 24 hours post-operatively. In terms of results, there were no difference in pain scores, no difference in terms of how much opioid burden was required from the PCA, no difference in the incidence of nausea, vomiting, or sedation. In fact, some of the patients actually had their bup dose lowered on post-op day 0 or post-op day 1 to try to get less buprenorphine on board and allow for more pain control, or that's what the providers were, that was the line of thinking that they were following. But those patients, if you separated them out, used significantly more PCA than patients that received their typical bup dose. So we likely had to overcome that opioid deficit by giving more PCA when we lowered the bup dose in patients rather than just continuing home regimen and restoring that opioid deficit. This next one is probably my favorite study in the presentation. It's a 2020 retrospective observational study with 55 patients in it. These were surgical patients with a variety of different procedures maintained on bup for OUD prior to admission. 38 of the patients had their bup dose continued, 17 of them had it held. And then the study compared those two groups, and they looked at post-op outpatient opioid dispensing, PACU pain scores as well. And again, these were patients that were either continued or discontinued off of their buprenorphine maintenance therapy for OUD management. So this is the closest study that we have to the patient population that we see most often. So the results showed that the number of opioid prescriptions dispensed was significantly higher with buprenorphine continuation, as was MME dispensed. PACU pain scores were higher with buprenorphine discontinuation as well, and that was statistically significant. So this just goes to show that in these patients, we can, again, still have, better pain scores in the PACU. We can have a lower number of opioid prescriptions needed at discharge, and a lower opioid burden needed at discharge as well. And all of this was statistically significant. Supporting literature. So there was a 2020 systematic review that wanted to determine an evidence-based approach for pain management in patients on bup in the perioperative setting. So this is just bringing it all together. They included 18 publications, many of which were case reports, some were case series, and then they had some retrospective cohort studies in there as well. And the conclusion from looking at all of these different publications was that there is no clear benefit to bridging or stopping buprenorphine in a perioperative setting, that failure to restart buprenorphine may pose concerns for relapse, which can lead to overdose and overdose-related death. And the recommendation was to continue bup in the perioperative period and incorporate multimodal analgesia when able. Very quickly, we'll go through some knowledge checks. So the first one, Suboxone contains both naloxone and buprenorphine. We use naloxone to reverse opioid overdose. Does this mean that the patient goes into withdrawal each time they take bup naloxone? No, they do not. We know that the naloxone component, when taken transmucosally, does not have any pharmacologic effect in most patients as long as they have healthy liver function. Knowledge check number 2, if somebody is taking full agonist opioids without telling me, and I give a full starting dose of buprenorphine, I will precipitate withdrawal. The answer is yes. So baseline in that patient is full agonist opioids. When we give a partial agonist, it's going to kick all of those off and cause precipitated withdrawal symptoms and be a functional antagonist. But that is simply because the patient's baseline is full agonist opioids and we're giving acutely buprenorphine. If we reverse this and someone is taking buprenorphine and you give full agonist opioids, you will not precipitate withdrawal. So let's pull up this lovely table that I think shows this very well. So buprenorphine by itself, of course, is going to occupy receptors at a high intrinsic rate. So it's going to find all of the opioid receptors, but it's going to give partial agonism, and then it's going to slowly dissociate off of those. The next is an agonist followed by buprenorphine. Buprenorphine will displace the full agonist and can precipitate withdrawal. And by agonist followed by buprenorphine, I mean a patient chronically maintained on agonist who's acutely given a single first dose of bup. Next, buprenorphine, which is what we're talking about here. So maintenance bup, long-term from patients, followed by an agonist. Bup remains on the receptors. You may see, and traditionally we thought the effect of the agonist being decreased, but really in more recent studies, and this is from an older textbook, this screenshot is, we have seen that good pain control is still something that we can achieve, and that still there are some receptors clearly that maintain available for agonism from full mu receptor agonists. Can a patient overdose on bup? Yes, they can. It's harder than other full agonist opioids that do not have kappa and delta antagonism and do not have partial mu agonism, but it can still happen, and it's a myth that it cannot. If a patient is on bup and in acute pain, adding full agonist opioids will not be effective unless bup is stopped. The answer to that is no, and that's of course the whole point of the presentation, of this section of the presentation at least. Okay, so what are some recommendations in terms of consensus guidelines or expert panels? So this first is a multi-society expert panel. So they had representation from anesthesia, pain medicine, anesthesiologists, as well as addiction medicine and pharmacists. And there was 100% consensus. They wanted to reach 75% consensus on what to do with buprenorphine in the perioperative setting. They reached 100% consensus on these two recommendations that you see here on the screen. Bupe should not be discontinued routinely in the perioperative setting to reduce the risk of OUD recurrence. Again, if we stop it, it's hard to get them back on it. Then we have an increased risk for relapse, overdose, and overdose-related death. The next one, Bupe can be initiated in untreated patients with OUD and acute pain in the perioperative setting to decrease the risk of opioid recurrence and death from overdose. So if a patient is untreated, meaning they're not on buprenorphine at baseline, but they have DSM-5 diagnosed opioid use disorder and acute pain, you can start buprenorphine. Now, how is that true from the knowledge checks that we just had? You cannot do a traditional induction. You have to do a rapid microinduction where you give really small doses of buprenorphine. We know from PET scan studies that mu opioid receptor occupancy from buprenorphine can be dose related. So we run a lower risk of precipitated withdrawal with lower doses given more often, slowly titrated up while we slowly titrate off the full agonist opioids as acute pain subsides, post-op day 3, day 4, day 5 after the patient has had surgery. So that's a very novel induction technique. Definitely consult pharmacy or reach out to me if you have a patient that could potentially benefit from this. But this is a recommendation from this multi-society expert panel, really just highlighting the importance of continuing or starting buprenorphine and how it can have a significant mortality benefit in patients. This is the Pain Clinical Practice Advisory that was published in May of 2019. Again, bringing it all together, saying that for all surgeries, elective or emergent, for all doses and formulations of sublingual and transdermal buprenorphine, for all expected post-op pain levels, and for all risk categories, we want to maintain buprenorphine at the same dose until the day of surgery. In the hospital, we want to initiate adjunct analgesia, and they have examples of what that means there. If the patient has an adequate analgesia that persists, you may want to consider initiating a highly potent full mu agonist on top of continuing the buprenorphine therapy. And that could include things like hydromorphone, morphine, or fentanyl. And then if that fails, you could consider reducing the buprenorphine dose, but that is not first line management. And then at discharge, we want to make sure that we're discharging the patient on a dose of buprenorphine and try to limit prescriptions for full mu agonists. Again, continuing to pull the data together. I won't take time to talk about these, but they are quick reads that I think do a great job of very quickly and easily explaining why we continue buprenorphine in a period of acute pain. And I think the titles are really catchy as well. So if you're interested and get a moment, take a second to read these and help yourself pull it all together. So strategies for continuing buprenorphine, I want to bring that home, and I alluded to this earlier. So the first option is to continue at usual home doses throughout an episode of acute pain, adding on short-acting full agonist opioids and multimodal analgesia as needed. Option 2 is to increase the buprenorphine dose up to 32 milligrams a day. This is from the clinical guidelines, but again, Kentucky law limits us to 24 milligrams a day, divided every 6 to 8 hours. And in Kentucky, you can only divide it every 8 or 12 hours. This is only the most reasonable strategy if we're doing mild to moderate pain that can't be controlled with non-opioid analgesics, like superficial cellulitis, for example. But again, Kentucky law does limit us from fully taking advantage of this option. If it's inadequate or if the patient has moderate to severe pain, option 1, continuing usual home doses and adding on short-acting opioids is your only option. So these are those Kentucky law limitations on the screen. Max daily dose of transmucosal bupe is at 24 milligrams, and you can only do Q12 or Q8, meaning BID or TID dosing, in patients that are undergoing active cancer treatment, hospice, palliative care, if they've had a surgery, and you can only do this acutely for up to 14 days, if they are pregnant, or if they are taking less than 16 milligrams of bupe per day. They do not mention allowing any QID dosing or every 6-hour dosing. And again, we give bupe more often in a period of acute pain, sometimes to try to maximize the duration of analgesic efficacy, which is only 4 to 8 hours. Buprenorphine, of course, has some effect on cross tolerance as well as a opioid agonist. So this was a 2019 match study, again, showing us that these patients are going to need more frequent titration and higher initial doses of short-acting opioids, as we would expect for any other patient that has cross tolerance. So these were surgical patients, only 19 of them receiving transdermal buprenorphine, so your Butrans patches. They looked at IV morphine equivalents required after surgery by patients maintained on Butrans trans versus opioid naive patients. However, if they had compared these to other opioid tolerant patients that were just maintained on a different opioid rather than bupe, you likely would have seen similar outcomes. So for this study, looking at comparing it to opioid naive patients, they found that post-op IV morphine requirements were significantly higher in the transdermal buprenorphine group compared to opioid naive patients, and that was statistically significant. Okay, so we want to add short-acting opioids to buprenorphine maintenance during a period of severe, moderate to severe undertreated acute pain. We want to anticipate that the patient's going to need higher than typical doses. So, if you start out at 5 or 10 milligrams of oxycodone, for example, starting off closer to 15 for these patients. And if that's ineffective, you can consider high potency options such as fentanyl or hydromorphone, which may have better efficacy. Buprenorphine calculations, very similar to methadone, are not typically reliable, which makes it difficult to find a good starting dose by just trying to take a percentage of their basal rate and then give it every 4 hours or every 6 hours for breakthrough pain. As we mentioned, we want to give higher empiric doses, around 15 milligrams of oxycodone, with the ability to titrate it very quickly. You may even want to consider giving this on a schedule rather than a PRN basis. Using IV boluses for rapid onset, control of severe pain in the ER or the PACU or post-op day 0, day 1, for example. And if these patients are consistently requiring IV opioids and can't get good pain control with oral therapy, considering a PCA, and then not adding on additional mixed agonists or antagonists. The last drug that we'll talk about is naltrexone. So we know that we typically don't use the oral formulation to treat opioid use disorder because of high non-adherence rates, which of course leads to lower efficacy and less astounding mortality rates. So typically we see patients come in on the extended release formulation, which is a 380 milligram deep intramuscular injection given every 28 days. The patients that would benefit the most from naltrexone are those that are highly motivated and or do not desire agonist therapy, which is considered first line by the American Society of Addiction Medicine. The biggest issue with naltrexone, other than lower retention rates to treatment, is that pain management is very difficult and requires reversal in the naltrexone blockade. And when we're talking about most patients being on an extended release depot formulation, that makes it even more difficult. We also know these patients have vulnerability to opioid overdose, especially if they try to overcome the naltrexone blockade on their own with illicit substances by giving themselves very high amounts. And that can be a safety concern. So how do we manage acute pain in these patients? First off, if we have long-acting opioid blockade, it makes sense to try to maximize non-opioid methods for a perioperative pain control. For the best efficacy, we're typically talking about ketamine, continuous infusion, or regional anesthesia techniques with peripheral nerve blocks or epidurals. If the patient is undergoing an elective surgery, you have some time to make sure that we get the naltrexone blockade off so that you are able to appropriately agonize mu receptors. So you would want to discontinue oral naltrexone if you find a patient on it at least 3 days before surgery, and discontinue long-acting naltrexone or the Vivitrol injection at least a month prior to surgery to allow it to completely dissipate so that you can have confidence that you have the ability to agonize the mu opioid receptors at standard dosages. If opioids are required while naltrexone is in effect, so an emergent surgery, for example, or trauma, you would titrate opioids to effect with monitoring in the ICU. So we're talking about really high doses to try to overcome that naltrexone mu opioid receptor blockade. An animal study in mice suggests that opioid doses around 6 to 20 times the standard dose may be required to reverse, which is why we monitor these patients in the ICU. I would recommend end-tidal CO2 monitoring as well for respiratory status. And that time in the dosing interval matters. So if we're in the first 1 to 2 weeks after Vivitrol injection, understanding that blockade is going to be pretty darn difficult to overcome. And we're going to need very high opioid doses, probably in the 10 to 20 times the standard range. And then if we're in week 3 or 4, some of the medication may have started to dissipate by then. So you may be able to be a little bit more conservative with your opioid dosing. So how do we treat acute pain in patients with untreated opioid use disorder? First, we want to screen for it. So, does the patient meet DSM-5 diagnostic criteria for opioid use disorder? We want to treat acute pain as clinically indicated. So the setting of severe acute pain is certainly not the time to attempt weaning or detoxification. Understanding those patients may need higher doses of your short-acting opioids because although they're maintained on illicit opioids, they do have a high level of physiologic tolerance and dependence that you will have to overcome. And we have we have an ethical obligation to make sure that we are treating true severe acute pain in patients. And then even though we're in a period of acute pain, it's appropriate to discuss treating opioid use disorder. Think back to that multi-society expert panel talking about how if a patient comes in for surgery and they have OUD that's untreated, we should still consider treating it to try to reduce the risk of relapse, overdose, and overdose-related death. So we can do this inpatient concomitantly with acute pain management with that microinduction technique without worrying about precipitating withdrawal. Or alternatively, you can do a standard induction and wait until the acute pain period has passed. So in conclusion, MOUD can reduce morbidity and mortality for patients with an OUD diagnosis. As an antagonist, naltrexone therapy can make unexpected acute pain very difficult to control, where we have to give 6 to 20 times the standard dose, and we have to utilize multimodal techniques. We can adequately treat acute pain while continuing opioid agonist therapy that's indicated for opioid use disorder, so like methadone or buprenorphine. And this may actually facilitate better transitions of care and even possibly decrease the need for additional high-dose short-acting opioid therapy. And as with any pain management plan, using the lowest dose for the shortest duration of action for your full mu opioid receptor agonist and utilizing a multimodal analgesic approach is paramount to success in following evidence-based practices. And with that, if you have any questions, please feel free to reach out to me at haley.bush@commonspirit.org. Be happy to answer any questions that you may have, and I hope you've enjoyed the presentation.